The sigmoid starts 15 centimetres from the anal verge and loops up for around 40 to 70 centimetres until it joins the descending colon. Inserting the colonoscope always pushes up a sigmoid loop. Seen in the lateral view, this sigmoid loop often spirals anteriorly against the abdominal wall, which is why hand pressure is used to oppose the sigmoid loop. How much the sigmoid can loop depends on the length of the sigmoid mesentery or mesocolon. When this is short, colonoscope insertion will activate stretch receptors in the bowel wall and mesentery and cause pain, especially in young patients with an irritable bowel. By contrast, a very long and mobile sigmoid, such as this, may loop amazingly, but with no pain because the long colon isn't unduly stretched. These have been so-called N or spiral loops. But another loop, endoscopically very advantageous, is the alpha loop. The alpha is effectively a volvulus produced by the colonoscope when the sigmoid is fairly long and mobile, but the descending is retroperitoneal, so forming a fixed tunnel up the lateral wall of the abdominal cavity. So, if the scope seems to be running in fairly easily, without any very acute bends and not much discomfort, an alpha loop may be forming, and the correct thing is to go on pushing. Let the scope run in to about 90 centimetres, which should be the proximal descending colon or the splenic flexure. Only then pull back with strong clockwise rotation to straighten out the loop and make the patient comfortable, also making the instrument easy to handle again. Let's look now at some of these sigmoid loops as recorded on the 3D imager. This is an N or spiral loop. See how mobile the sigmoid can be. Here's an alpha loop forming, and now the loop is being straightened by pull back and clockwise torque. Steering carefully and handling the scope properly, tracking through the sigmoid should usually take little time and present no great problem. However, the sigmoid is the most unpredictable part of the colon. Adhesions from previous hysterectomy or diverticulitis can cause fixation and difficulty. A paediatric colonoscope or even a paediatric gastroscope makes things easier. Even so, the view can be very poor. Underwater endoscopy occasionally helps in diverticular narrowing or stricture, water holding the folds away from the lens and giving a better view. The endoscopist should concentrate entirely on the screen view, even while talking to the patient. It takes concentration to follow the lumen in close-up, avoiding mistakes and redouts, and watching the vessel pattern in case the colon rotates. Small, coordinated movements are needed to torque steer or corkscrew through the sigmoid. Steer smoothly, keeping a sense of direction. Slow and precise steering movements avoid losing the view. Passing the bend at the apex of the sigmoid always means some push pressure. Warn the patient to expect some short-lived stretch pain, then pull back as soon as possible to reduce the loop and stop the pain. If, on pushing in, the instrument becomes hard to handle, an atypical loop may be forming. Here, it's because the descending colon is mobile on a descending mesocolon, which allows the tip to push the colon across medially, and this then requires some finger skill dexterity to keep the luminal view as the shaft is pulled back and straightened. An exaggerated example of an atypical loop, when the descending colon is very mobile on a persistent mesocolon, is a reversed alpha loop. This is an anti-clockwise spiral which can only be straightened out by torquing anti-clockwise while pulling back. Rotating and derotating the shaft often results in loops outside the patient, which makes shaft handling awkward. Straighten out the shaft by derotating the control body, so the loops are transferred from the shaft, where they matter, to the umbilical, where they don't. There may be up to 3 loops in the umbilical before it needs to be disconnected from the light source and straightened.